Thanks very much, Rosaleen, and thank you to all the organisers for the invitation to speak today on H110D and other variants of ATTR amyloidosis. Now, I'm based down in Cork, where we've identified 2 families to date who have this mutation, one of whom is part of a large multi-generational kindred with a lot of affected family members. Now, if you're reading this slide and you've got to the part where it says it's particularly prevalent in the region of Donegal, you might be forgiven for thinking, surely that's incorrect. And you'd be right. But this is actually what ChatGPT thinks. So it might be good for the odd business case, but actually it doesn't know a lot about TTR just yet. So it's back to the books, the existing published literature to tell us a little bit more about this mutation. So this is H110D, or legacy H90D, and it's a substitution of histidine, denoted as H, a basic amino acid, for aspartate, an acidic charged amino acid. And the story, if you will, starts in 1989. So it was a wet summer, but I didn't seem to mind because I just finished some exams. Some other interesting things were happening in the world. For some, this was the greatest event of 1989. I think if you know, you know. And on the more academic front, in CERN, Tim Berners-Lee was producing his first proposal for the World Wide Web. Almost inconceivable now to think of a world without it. So it was against this backdrop that the first paper denoting a mutation at this site at histidine 90 was published by James Scare. The pedigree is shown on the top right. So the index case was a 39-year-old lady of Italian-Sicilian origin who presented with a neuropathy with autonomic involvement and cardiac involvement. And you can see there she had an affected mother, maternal aunt, and uncle. And the mutation was not in fact H90D, but it was a substitution of histidine for aspartame, denoted N. And they conducted a so-called, asparagine rather, denoted N. They conducted a hydrophilicity profile to give a sense of the change in structure. And they concluded it seems most likely that replacement of the slightly basic His90 with a neutral amino acid might result in the observed shift. And they thought that might explain pathogenesis. Unfortunately, over the next couple of years, there were a lot of conflicting reports in the literature in relation to this variant. This paper was from a German and Portuguese cohort where they identified a lot of patients who carried this variant but did not seem to have the disease. It was quite a young cohort, only up to the age of 58, so it's possible it didn't have time to manifest. But there was one patient who was symptomatic from the Portuguese population, but they carried the known pathogenic V30M mutation, so they therefore discounted H90N as a pathogenic mutation in that case. But by contrast, the next year, a different family was published in the literature, again of Italian origin, and they did carry this mutation and did have the HATTR phenotype. However, James Scare went back to the original family who he had described, and in fact, on closer review of the gene, found that the family in fact co-inherited 2 mutations. One was glutamate 42 glycine, and that was known to be pathogenic already in a Japanese family. So they revised it and said, well, probably that's the pathogenic mutation and not the other one. And then more recently, in 2009, a 46-year-old man who had an intracerebral hemorrhage was found to carry that variant. He didn't have a neuropathy, and they felt again it was probably coincidental. So it's against that background of a bit of confusion that the first patient presented to our service in 2006. This was a 79-year-old lady who presented to me with a 5-year history of progressive gait decline and loss of dexterity. On a background 10 years prior of bilateral carpal tunnel release and 1 year previously of pacemaker insertion. And the GP letter shown in the top right there was referred to me as a muscular dystrophy, but clearly the pattern was more in keeping with an autosomal dominant polyneuropathy. And as chance and luck would have it, this patient's sister was coincidentally an inpatient in Queen Square under the care of Professor Riley. So the H110D variant was identified and also in the patient's sister. But because of what I've told you about the previous background and the query about mutagenesis at this site, the previous variant being a little bit unclear, it was initially a little bit uncertain as to whether this mutation was pathogenic. But as more family members presented clearly with the phenotype, as you can see here, the conclusion was that this was in fact a new and pathogenic mutation. So the first report in the literature was in 2015, and the authors addressed the issue of the different substitutions at this point. And they used something called a molecular visualization tool to try to explain this. And the graphic here you see on the left-hand side, you see wild-type TTR. And I'm not sure if you can see, hopefully, but the dotted lines represent stabilizing hydrogen bonds, which you can see to the side chain and to the main chain. And then for the middle, for the H110, you can see there's a conformational change, but you still have some hydrogen bonds formed. By contrast, for the more recently described H110D, no hydrogen bonds can be formed because of the torsion of the side chain, making it more unstable, and this was thought to explain the pathogenicity. So we then went back to look at the original kindred, and we identified 17 different members across 4 generations who carried this mutation. We didn't have genetics on all of these kindreds, so some of this was a retrospective review based on history and old charts. And we looked at the incidence and the age of onset of symptoms, such as carpal tunnel syndrome, polyneuropathy, cardiac involvement, gastrointestinal involvement, and autonomic involvement. And during the course of this work, we identified a second unrelated family, shown here, the pedigree on the right-hand side. And the index case in that situation was a lady in her 70s who we were asked to see on consult rounds with a debilitating neuropathy with autonomic involvement. And she had one affected daughter who also has carpal tunnel syndrome, and the other siblings did not come forward for investigation despite requests to do so. So Dr. Marwa Assad was a specialist registrar working with me at the time, and she did really nice detailed work collecting all this data and describing the phenotype, and published this in 2022 with nice input from our neuropathology and neurophysiology and cardiology colleagues, shown here. So this slide summarizes the phenotype. It is predominantly a neurological phenotype. Bilateral carpal tunnel syndrome is the first manifestation most typically, with a median age of onset in the mid-50s. And this is followed some years later by a polyneuropathy. Now, what we've observed is the degree of polyneuropathy is really quite variable, from being very mild with some sensory symptoms to being quite an aggressive, debilitating, progressive neuropathy. And the clinical photographs you see on the bottom left are from a patient at advanced stage of disease, wheelchair-bound at this point, and you can see a lot of weakness and wasting of the hands. And we've also seen dysautonomia in later stages. And there is non-neurological involvement. Cardiac involvement was common in those over the age of 60, but the median age of onset was into the 70s, so a little bit later than some other mutations. We also saw gastrointestinal involvement. And you can see here the cardiac MRI on the bottom right shows you some of the characteristic features with interventricular hypertrophy and what we see as subendocardial late gadolinium enhancement, which is, I'm just going to point that outline here, which we see. And this is a table summarizing our current cohort. So we have 9 genetically confirmed patients with this mutation. 1 patient pending review. I think they're due to come to see me on Tuesday. And you can see the age, they're in their 50s or early 60s. Carpal tunnel syndrome, bilateral carpal tunnel syndrome, is the most common presenting feature, apart from 1 patient who just has a unilateral carpal tunnel at the age of 60. They're all in a quite early stage of neuropathy, stage 0 or stage 1, apart from the bottom patient who unfortunately passed away, had a very aggressive neuropathy, and that was just was already wheelchair-bound and missed the sort of treatment era. Cardiac manifestations at this stage are quite uncommon, but the patients are probably a little bit too young for it. And in terms of those who have a stage 1 neuropathy, 3 are on treatment with vutrisiran, and 1 patient participated in the CRISPR-Cas9 gene editing study in 2021, and we continue to follow him, and he's also followed up at the National Amyloid Centre, and thankfully he continues to do very well. So outside of these 2 families, there were no other reports of this mutation, until last year. This was a group in UCLA who published this in the Canadian Journal of Neurosciences. Again, it's in an American family of Irish descent. And the index case is a lady in her 70s who presented with quite dramatic weight loss, symptoms of autonomic dysfunction, and a rapidly progressive neuropathy. And on examination, she was quite cachectic. She had lost about 20 kilograms of weight. She had postural hypotension, and she had clinical evidence of a significant neuropathy confirmed on neurophysiological testing, also with bilateral carpal tunnel syndrome, and also had evidence of cardiac investigation. And this patient died 9 months after presentation to their service and only 4.5 years into her symptom onset. They conducted a detailed post-mortem study and showed evidence of widespread amyloid deposition in the myocardium, shown in panels A and C on the top on the left, in peripheral nerves, shown below, involving both the vagus nerve and the sciatic nerve, shown here, and also central nervous system involvement with deposition of amyloid in the vessels in the choroid plexus. So very widespread deposition. So this patient's father was or died at the age of 70 with a 5-year history of debilitating neuropathy, and he did have an autopsy, and amyloid was the diagnosis given at the time. And this patient's son is in his 50s, previously had carpal tunnel release, and is mutation positive and is on a treatment. So I managed to connect with the corresponding author about 2 weeks ago by Zoom, because I was particularly interested to know what part of Ireland this family had come from. And interestingly, they did have a copy of the immigration card of this patient's father, who came to the States in 1883. And it says that he was from, not from Cork, but from the north of Ireland. So maybe ChatGPT knows something after all. Okay, so we've a lot of evidence of pathogenicity for H110D. But going back to what I told you, H110N, is that perhaps non-pathogenic? Well, maybe not, because this was a paper from last year that showed successful treatment with patisiran in 2 unrelated families who carried this variant, who did have clinical and biopsy evidence of amyloid. So I'm just going to summarize this section of the talk first and say for H110D, we've clear evidence of pathogenicity, we've a large Irish kindred, a second family identified, and now a third family unrelated of American-Irish family. So this mutation is out there. It does have a characteristic phenotype with bilateral carpal tunnel syndrome as an early manifestation, followed by some degree of neuropathy, which seems variable at a later stage, but can be quite rapidly progressive, and the cardiac involvement tends to come later. Like many mutations that we've talked about and you've heard about today, some patients seem to have a milder phenotype, some have a more severe, and we don't really understand why that is. So clearly there are other factors modifying the presentation. And for H110N, possible, if not probable, pathogenicity is probably where we land for the moment. So I was asked to talk about a few other HATTR variants. And this map shows you the geographic origins and distributions of the 3 most common mutations worldwide. And of course we have the V30M mutation, the most common in Europe, and we have the V122I in the United States and Western Africa, and our own, of course, T60A here and in the United Kingdom. And you've seen similar slides before, and we know that some mutations are probably presenting mostly to neurologists, some are presenting to cardiologists, but mostly it's a mixed, or as others have said, it's a multisystemic disease, and that's the way we need to think about it. And this is a figure that gives you an estimate for the global prevalence, but of course it will be much higher in certain endemic areas. More than 130 different TTR mutations described. I'm not going to get into all of them, don't worry, just a few representative ones. We've spoken a bit about how heterogeneous the clinical phenotype means, how different it can look. Even between 2 related family members, they can manifest with quite different symptoms. And it's worth saying not all mutations are pathogenic. So there is a stabilizing mutation, the threonine 119 methionine, which if you carry this mutation, for instance, together with the V30M, either you don't manifest the disease or to a much lesser degree, and that's been shown to do so by stabilizing the TTR tetramer, slowing its dissociation. And there are many other factors which influence the phenotype or the disease manifestation. Of course, the type of mutation is the main one, but you see here there are many other factors, from age, from geographical location, from the type of fibril, from the gender, and probably modifying genes that make up the phenotype. And I know Professor Riley talked a little bit about the V30M, and I hope I'm not overlapping too much, but just to address this, as it's the most common mutation worldwide, first described in Portugal as a peculiar form of neuropathy in a very detailed report on 74 patients. And as you've heard earlier, the onset typically tends to be in the second or third decade, with symptoms of a small fibre neuropathy progressing later to a sensory motor neuropathy, but you do get the autonomic dysfunction, cardiac involvement, and vitreous involvement. But there is this difference between late onset and early onset V30M, and the late onset here is highlighted in the darker blue. In countries such as Sweden and the United States, it's somewhat more prevalent. And this is the V30M late onset phenotype. It tends to occur in the 6th decade. Males are more commonly affected, and the penetrance is lower. And again, the symptom onset you see here on the right-hand side, beginning with lower limb sensory symptoms of paresthesia and pain, subsequently involving motor symptoms, then with autonomic involvement and cardiac involvement. It can often take a longer time to diagnose this, and the misdiagnosis rates are actually quite high and reported as high as 68% in some studies versus maybe 26% for the early onset phenotype. And this is just some data from a Brazilian cohort of the late onset V30M, highlighting the neurological features. And it's predominantly a neurological phenotype, as you can see here on the bottom graph, where the dark represents the late onset. And you can see most of them either have sensory or motor neuropathy. And on the top, you see symptoms such as muscle weakness and balance difficulties are particularly common in this group. But they do also get cardiac involvement, and they seem to have a higher incidence of ECG abnormalities and interventricular septum hypertrophy at presentation. So I'm switching to another mutation now. That's a neurological predominant phenotype, and the V122I has more a cardiac predominant phenotype, as we've heard already, more common in the USA with a 3 to 4% prevalence in the black population. You can see in this figure here on the right-hand side, comparing 3 different mutations, that the incidence of, or the cardiac presentation rather, was at 97%. And I also just highlighted the age of presentation, so it tends to be a little bit older, into the 70s. But we do see neuropathy with this mutation as well, sometimes as a co-presenting feature. And we do, of course, see carpal tunnel syndrome in addition. And as others have said, identifying this and awareness of this, of course, gives you a window of opportunity to diagnose it and initiate treatment a little bit earlier. And the third mutation I'm going to mention is the 89Q, because this has a mixed phenotype classically. It's more prevalent in Italy and Bulgaria, and it's gender neutral. The orange here shows you the mixed phenotype, but the interesting point about this was that it was quite different in different countries. So for instance, in Bulgaria, they seem to have a higher incidence of cardiac manifestation, whereas in Italy, not that far away, they had a higher incidence of predominantly neurological phenotype. So what might be the reasons for that? They postulated maybe a longer duration of symptoms in Bulgaria, perhaps referral bias, perhaps some genetic factors. I'm just going to skip that. And in my last 2 minutes, I'm just going to mention apolipoprotein A1 as a non-TTR hereditary amyloid, because it may be of relevance to some here. And this is the third most common type of amyloidosis in the UK overall, originally described by Van Allen in 1969, and it became known as the Iowa kindred after the region where it was first identified. And the onset is in the 30s with a neuropathy similar to TTR. It was noted initially in the first report that they had a high incidence of gastric ulcers and renal failure, which seemed to differentiate it from what was called familial amyloid polyneuropathy at the time. And in 1990, the first pathogenic mutation was identified, shown here at lysine 26 arginine. And now more than 18 different mutations have been described. And it is a multi-systemic, slowly progressive disease with amyloid deposition in lots of different tissues. And while we do see neuropathy, it's not really the most common tissue that's affected. The kidney is very commonly affected, leading to proteinuria and hypertension, but you do see other organ systems involved with the liver, cardiac involvement, sometimes the larynx causing dysphonia, and testicular involvement causing hypogonadism or infertility. And this was a paper from a couple of years ago from the National Amyloid Centre looking at the outcomes of 57 patients with APOA1, 18 of whom had organ transplantation. And you can see the most common variant was that glycine 26R, and the vast majority of the patients were of Irish ethnicity. And looking at the presenting features, again, mostly it was a renal phenotype, proteinuria, hypertension, chronic kidney disease. But one patient, with my neurologist hat on, one patient did present with an amyloid type peripheral neuropathy. But I suppose what I would take from this is it's important for us as neurologists when we're on the renal wards to maybe think about this disease as well as a differential for neuropathy. And of course, there's no disease-modifying therapy available for this type, but organ transplantation is an option. And the outcomes here from this report showed that the median renal allograft survival time was about 22 years, which obviously is fantastic for patients in terms of quality of life and disease management. So I'm going to summarise here. This is just a summary of what I've covered. Obviously, there are many other mutations and phenotypes, including things like the ocular leptomeningeal type of amyloidosis, which Mary mentioned earlier on. We're seeing evolution in the different phenotypes as patients live longer. We're seeing new mutations such as the H110D coming through, maybe due to heightened clinical suspicion now because we're in an era of therapeutics. And I think as others have said, and I would certainly echo it, the goal for us all here is early diagnosis and access to treatment. And so our awareness and clinical suspicion is paramount for all types. Thank you so much for your attention.